Okay, let's talk about PCOD, PCOS. But today we'll talk about PCOS or PCOD from JB Sharma. PCOD is the single most common heterogeneous multi-system endocrine abnormality of women of reproductive age group. The most common cause of secondary amenorrhea. It is characterized by menstrual irregularity, hyperandrogenism, obesity, polycystic ovarian in ultrasound. Discovered by ACU American gynecologist Steen Leventhal 1935, and hence is called as Steen Leventhal syndrome in the past. The incidence, worldwide incidence is 6 to 10%, being more common in 20% of infertility patients. It has become more common due to change in the lifestyle and increase in stress level. Also becoming more common in adolescent gland upon developing soon after puberty. The Diagnostic Area 2003 Consensus Workshop on PCOS sponsored by ASR and AS3. 2 out of 3 criteria should be present to make a diagnosis. These are the called rotoderm criteria. Any 2 of the 3 rotoderm criteria are noted, make to the diagnosis up to the cause of androgen excess, adrenal tumor, ovarian tumor are excluded. In adolescent, all 3 criteria to be satisfied. Androgen PCOS Society 2006 tightened the criteria, suggest including all the 3 rotoderm criteria to make the diagnosis of PCOS. What is the etiology? The exact etiopathogenesis. The exact etiopathogenesis is not established. Many pathophysiological hypotheses have been proposed to explain the symptomatology of PCOS. Well, first one is the insulin hypothesis, that is insulin resistance. It is currently the most accepted hypothesis to explain PCOS. It is proven that insulin resistance and resultant hyperinsulinemia is observed in 50 to 70%, even more in obese patient with PCOS. Hyperinsulinemia results from an increased basal secretion of insulin and decreased hepatic clearance of the insulin. Two is, one is the decreased basal clearance of insulin. Okay. Second one, increase basal secretion of insulin. Okay, let's talk about the etiopathogenesis of PCOS. The insulin hypothesis, that is insulin resistance, it is currently the most accepted hypothesis to explain PCOS. It is proven that insulin resistance and resultant hyperinsulinemia is observed in 50 to 70%, even more in obese patients. Okay, the patients of PCOS having hyperinsulinemia result from how this hyperinsulinemia occur, because two things. One is the increased basal clearance of insulin. Second, decreased increased secretions and decreased clearance. This is the enough. There is impaired suppressions of hepatic gluconeogenesis and inhibitions of hepatic production of sex hormone binding globulin. What happen? There is impaired suppression. There is impaired suppression. There is no suppression. Difficult to suppress. Difficult of suppression of the hepatic gluconeogenesis and inhibition of hepatic sex hormone binding globulin secretion. that leads to increased free testosterone level in the circulation, that leads to hirsutism. Okay, in PCOS patient, there is decreased glucose transport in adipocytes, leading to increased circulating free fatty acid level, which in turn produce peripheral insulin resistance. Because of increased free fatty acid level, increased free fatty acid, that lead to increased peripheral insulin resistance. Okay, then that insulin resistance is hence the glucose, that is insulin resistance is 30 to 40%. Hence glucose in blood remains elevated for a longer time. That will stimulate what happen if your glucose increase in your blood, increase in your circulation for a longer time. That will stimulate your pancreatic islet beta cells to secrete more insulin, causing more hyperinsulinemia. Remember, then what happened, those insulin increase, they how they act through insulin growth factor 1 receptor. Elevated serum insulin may act by insulin like growth factor 1 receptor on ovarian theca cells. These insulin like growth factor receptor 1 located on ovarian theca cells, that these insulin directly act through this insulin like growth factor receptor, and that stimulate the ovarian theca cell, that theca cell hyperthecosis, that lead to increased production of testosterone or more androgen, as ovarian cells remain sensitive to insulin in producing androgen. Okay, insulin also stimulate LH to cause hyperplasia, LH to cause hyperplasia of the ovarian theca cells, which what happened, that insulin also stimulate the LH what happened, LH called hyperplasia theca cell, that will secrete more androgen, testosterone, epiandrosterone. Peripheral adipose tissue convert this epiandrostenedione ion to estrone, leading to increased estrogen level. The estradiol level remains normal. Diol, remember the diol level, estradiol levels, estradiol level remain normal. Remain normal, but estrone 1, that is increase. High androgen level, that will inhibit the, what happen when there is high androgen level, that will inhibit the growth of dominant follicles. Remember, when there is excess androgen, that will inhibit the dominant follicle growth and prevent the apoptosis of smaller follicle, which normally disappears in the late follicular phase. What happen, they prevent the excess androgen, prevent the growth of the dominant follicle, and prevent the apoptosis of the smaller follicle, which was normally has to be disappear in the late follicular phase. That's why thus many small follicle persist, that is this atretic follicle, that is the hallmark of Pcos. The neuroendocrine hypothesis, this is according to this hypothesis, that is neuroendocrine hypothesis, there will be a gradually increase in testosterone level during puberty, may gradually impair inhibition of daytime GNRS per progesterone in girl destined to develop PCOS. It cause this difficult impair inhibition of GNRH, that lead to increased GNRH pulse frequency. If GNRH pulse frequencies increase, which favor the LH productions over the FSS production, hence there is rise in increased LH FSS ratio, because LH is increased but FSS decrease. The relative FSS deficiency, what happen when there is FSS deficiency, that will prevent the aromatization with the granular cell aromatization of androgen to estrogen in the ovary, which impair follicle maturation, cause anovulation. Because of relative FSS deficiency, interferes with granulosa cell aromatization that will because of deficiency of the FSH. Because of deficiency of the FSH, there will be a preventing the granulosa cell. The granulosa cell, the FSH receptor located in the granulosa cell. So the granulosa cell unable to do the aromatization from the androgen to estrogen in the ovary, which impair. If estrogen is not there, there will be impair in the follicular maturation that will cause an ablation. Okay, the increased pulse frequency, LH pulse frequency. Remember, this LH is the very LH pulse frequency that will induce ovarian thicker cells hypertrophy that will produce more androgen. That will further this more androgen further make GnRH pulse regulator that will more insensitive to the increase LH pulse frequency induce ovarian thicker cell to produce more androgen, which further makes the GnRH pulse regulator more insensitive to progesterone, cause further ablation. Then ovarian hypothesis. Ovarian hypothesis. The three one is insulin resistance, neuroendocrine hypothesis, ovarian hypothesis, low-grade systemic inflammation, genetic factors, and any other factors like genetic, environmental, multifactor, polygenetic factors. The ovarian hypothesis, it was thought in the past that there was a primary defect in the ovary. Previously, that there is some primary defect in the ovary, which was polycystic and secreted more androgen, causing anovulation. However, now they remember it is now known that it is secondary to insulin resistant and increased pulse frequency, LH pulse frequency. In Pcos, the thicker cells have generalized overactive steroidogenesis with increased androgen and increased estrogen. But remember this decreased progesterone. Decreased progesterone due to failure of corpus luteum development and anablations. It leads to, when there is decreased progesterone, that leads to on oppose. Remember this keyword you have to tell in the examination. On oppose action of estrogen on endometrium that leads to endometrial hyperplasia, atypical hyperplasia, endometrial cancer over years. Remember. Then the fourth is low-grade systemic inflammations. That is, various studies indicate low-grade chronic inflammations in Pcos as evidenced by increased level of markers of inflammations like C-reactive proteins, interleukin 8, tumor necrosis factors alpha. All these factors, it leads to developments of insulin resistance, dyslipidemia, endothelial cell dysfunctions, metabolic and cardiovascular long-term complications of Pcos. This cluster of disorders is known as metabolic X syndrome. The development of insulin resistance, dyslipidemia, endothelial dysfunctions, metabolic and cardiovascular long-term complications of Pcos. This cluster of disorder also known as metabolic syndrome or X syndrome. The genetic factors play also a role in the Pcos developments. This factor is low-grade systemic inflammation. Low-grade chronic inflammation leads to Pcos by CRP, IL-18, TNF-alpha. This leads to development of insulin resistance, dyslipidemia, endothelial dysfunction, metabolic, cardiovascular long-term complication of Pcos. Then the genetic factors. The genetic factors play a role in the Pcos as it is 8 times, remember, 8 times more common in daughter of Pcos patients. There is also a family history of type 2 diabetes mellitus in 80% of cases. It tends to multifactorial, polygenic, with some cases of having autosomal dominant inherited factors. CYP21, remember the gene CYP21 gene mutations has also been blamed in its etiology. Then the genetic factors. First one is insulin hypothesis, insulin resistance, hyperinsulinemia, ovarian hypothesis. The neuroendocrine hypothesis, that is LHFS imbalance, LHFS ratio imbalance, that will lead to anovulations, progesterone decrease. Then the third one is the ovarian hypothesis, because of LH short, because of LH induced FSH is not there. There will be aromatization, defective aromatization, ovarian hypothesis, failure of ovulation, thicker cell hypertrophy, steroidogenesis, low grade systemic inflammation, interleukin 8, 18, TNF alpha, everything's that metabolic X syndrome, genetic factors, 8 times more common in the data of Pcos patient, primary history of type 2 in 80% of relatives, tend to multifactorial polygenic mutations, CYP21 gene mutation has been blamed in etiology, environmental factor, this is also important in several cases of Pcos due to change in diet, lifestyle, stress. Multifactorial polygenic factor in not cells, PCO is caused by insulin resistance, hyperinsulinemia, increase androgen productions, decrease progesterone, anovulation, decrease FSH, increase LH, increase estrogen, but that is not the potent estrogen. It is estrone 1, not estradiol. With chronic inflammation causing long-term complications like dyslipidemia, diabetes, cardiovascular disease, long-term cardiovascular disease, and endometrial carcinoma PCOS. Okay. Then what is the clinical feature? These are the etiopathogenesis, the hypothesis, insulin resistance, neuroendocrine hypothesis, ovarian hypothesis, genetic factors, multifactorial genetic factors, and this environmental factors, multifactorial polygenetic and chronic systemic inflammations. The clinical feature, there is heterogeneous vary in severity. They usually manifest at puberty along with weight gain. The most common feature is menstrual dysfunctions with hirsutism and obesity. These three. The first one is menstrual disorder. The most common symptom occurring in 60 to 85% of PCOS patients. The menarche may be normal or earlier. Menstruation may be normal for a few years, but then infrequent menstrual bleeding, that is oligomenorrhea, develop in almost 85% girls with a short period of amenorrhea in about 50% of girls, followed by prolonged heavy bleedings. This is the menstrual disorder. Menstruation may be normal for few years, then they have an infrequent menstrual bleeding, that is oligomenorrhea. That develops almost 85% of girls with a short period of amenorrhea in about 50% of girls, followed by prolonged heavy bleedings. As there is anovulations, dysmenorrhea usually absence. Okay, remember this key point, dysmenorrhea is usually absent. That is anovulations. So rarely there may be a primary amenorrhea, rarely, but this usually respond to progesterone challenge test because this estrogen is there, but progesterone is not there because of anovulation. So if you giving outside progesterone, that will the endometrium after withdrawal, that will leads to bleed. Okay, remember this thing. Then hyperandrogenism, they are usually the signs of androgen excess, which manifest as excess terminal hair, body hair, maldistribution pattern of body hair. Thus, there is a hirsutism in 65 to 75% cases. Menstrual disorder is 60 to 85%. 65 to 75% cases of maldistribution hirsutism. The hair leaf on upper leaf, on the chin, around the nipples along the linea alba of the lower abdomens. Acne is commonly seen in Pcos, 30% of cases. Seborrhea also seen. Alopecia in 4 to 5% cases. In extreme form of Pcos called hypertrichosis, there may be clitoromegaly, increased muscle mass depending on the bias. However, it is rare. The patients of this picture necessarily differentiate from the. So, when there is a clitoromegaly, usually in Pcos there is less chance, but this is rare. Increased muscle mass depending bias, this however it is rare. There's presence of this feature, the scleromegaly, increased muscle mass depending the boys, that more towards to the androgen producing adrenal or ovarian tumors. Androgen can be produced by the adrenal, so it can be adrenal tumors, or it can be produced by ovary, so it can be ovarian tumors, or congenital virilizing adrenal hyperplasia, or the patient can be taken from the outside exogenous androgen intake administration. This is the four differential diagnosis. If the patients have developed cliteromegaly, muscle mass increase depending on the bias, these are the rare finding in PCOS. So you should go for other diagnosis, differential diagnosis, androgen producing tumor. It can be adrenal, it can be ovary. This is adrenal ovary tumors or ovarian tumors, congenital virilizing adrenal hyperplasia, or exogenous administration of the okay. I already told the etiopathogenesis of the PCOS, let's say recalls, that is hypothalamus, pituitary, that increase LS and decrease FSH. The adrenal produce increase androgen production, decrease sex hormone binding globulin, increase testosterone level 3, that lead to hirsutism. Then ovary is the key. Ovary is hypertrichosis, products excess androgen that lead to again these cycles. Then insulin resistance, chronic inflammation, CRP, interleukin 18, dyslipidemia, that's metabolic X syndrome, dyslipidemia, endothelial dysfunction, diabetes, cardiovascular disease, increase inhibin level, increase peripheral conversion to estrone, increase estrogen level, on-off action of endometrium, lead to endometrial hyperplasia and cancer, decrease follicle maturation because of excess androgen production, follicular atresia prevention, decrease aromatization causes development of multiple small follicles, that is lead to because of prevention of atresia, dominant follicle unable to develop, that lead to multiple follicular development, that is small follicles, that lead to PCOS morphology. Okay. Then first one is the menstrual disorder, second one is the androgen excess symptoms, third one is the obesity. About 50% of PCOS patients have abdominal obesity with waist circumference more than 35 inches, that is 88 centimeter, more than 80 centimeter in Indian women. It is measure how we measure the abdominal, how you will measure the waist circumference. It is measured between the 12th ribs and the iliac crest. Remember, iliac crest and 12th rib midway between the hip circumference is measured at the level of greater trochanter, broadest part of the lower body. If you get increased waist hip ratio, it is indicative of central obesity and causes metabolic syndrome. It may also be part of metabolic syndrome in the advanced PCOS patients are more prone to develop atherosclerosis, impaired glucose tolerance, type 2 diabetes mellitus 10% by account by about 40 years of age. The obesity is assessed by BMI, that is BMI weight in kg by divided by height in meter square. BMI is 18.5 to 24.9 kg per meter square is normal body weight as per other country. 25 to 29.91 kg overweight, while BMI is more than 30 is obesity. In India, the limit is 23 overweight, more than 23 is overweight, more than 25 is obesity. Then next is infertility. In the reproductive age group, the infertility is very common. Maybe the presenting feature 40 to 50% of women. It is usually due to anovulation. However, the cause of anovulation, then infertility. Infertility is in the reproductive age group. The infertility is very common. Maybe presenting feature 40 to 50% of women, it is due to anovulation. However, the other cause of anovulation should be also to be rolled out. There is increased risk of miscarriage and pregnancy loss them due to increased LH level and increased chances of impaired glucose tolerance, hypertension, diabetes mellitus, hypertension during pregnancy, continuation of the insulin sensitivity like metformin after consumption may decrease the miscarriage. This another thing is acanthosis nigricans. The presence of diffuse velvety thickening and hyperpigmentation of the skin of the nape of the neck, armpits, axilla, underneath of the breast, the exposed area like elbows and knuckles. It is due to insulin resistance. Seen in 5% cases of PCOS. Heron syndrome, PCOS patients is acronym for hyperandrogenism, insulin resistance, androgenic acanthosis nigricans. Sleep apnea. Some women with the PCOS, especially with obesity, have obstructive sleep apnea syndrome with episodes of apnea and hypopnea during sleep. It also is factor for cardiovascular disorder in patients with PCOS. Hypertension. PCOS patient has a metabolic syndrome tend to have elevated blood pressure. The systolic is more than 130 and diastolic is more than 85. They may also more prone to develop preeclampsia during the pregnancy. The psychological feature, all these girls are obese, so there is acne and hirsutism. The menstrual dysfunction, they tend to have poor self-esteem, depression, up to 40% of cases, more common in obesity, insulin resistance cases. Anxiety, negative body image, eating disorder, 12% cases, social phobia, reduced quality of life. What are the differential diagnoses? Various non-PCOS condition can also cause menstrual disorder. And hirsutism, late onset congenital adrenal hyperplasia, there will be elevated 17-hydroxyprogesterone level. The androgen secreting tumor of ovary, that is adrenoblastoma, raise total testosterone. Ultrasound also helps. Androgen secreting tumor of adrenal glands, raise DHES, dihydroepiandrosterone sulfonate. Cushing syndrome is raised 24-hour urinary free cortisols. Hypothyroidism, raised TSH. Hyperprolactinemia, raised prolactin level. Exogenous androgen administration, history of drug intake. Hypothalamic pituitary ovarian dysfunction like hormone like FSH, LH, estradiol level helpful. Pregnancy in case of amenorrhea, positive urine pregnancy test. The diagnosis, how you diagnose: the history taking an examination, the history of lifestyle, diet, smoking, stress, any hormonal medication is asked. Family history of diabetes, hypertension or metabolic syndrome, any history of excessive exercise, tuberculosis, thyroid disorder. Diagnosis species suspected from typical history for menstrual dysfunctions, infertility, infrequent menstrual bleeding of amenorrhea followed by hyperandrogenism, acne, hysterectomy, acanthosis nigra, alopecia, obesity, infertility. In examination, general physical examination, the obesity, especially waist hip ratio, is more than 0.72, various insulin resistance in PCOS, and BMI is more than 30 kg per meter square. Also favor PCOS. Look for signs of hyperandrogenism like alopecia, acne, hirsutism. If hirsutism is present, it should be quantitative by grading. Also look for acanthosis nigricans. The blood pressure should be measured, especially in the obese women. May elevated heart and chest examination usually normal. Abdominal examination may show central obesity. Gynecological examination, pelvic examination not done in non-married, non-sexually active women. Ovaries may be enlarged and palpable. All the investigation not needed for every patient. Ultrasound transvaginal sonography on married girls is most important in making diagnosis, but is not mandatory. The ultrasound feature like 20 follicles. Now they changed 20 follicle. Peripheral arrays follicle measuring 2 to 9 mm. Increase ovarian volume more than 10 ml. Hyperechogenic enlarged central stoma along with above 3 features of PCOS. Ultrasound can also detect to rule out any ovarian tumors, any endometrial hyperplasia. Ultrasound usually performed to early follicular phase. Increased blood flow may observe in Doppler ultrasound. Ultrasound also useful for observing in the response to medication. May help in decision about stopping the medication. However, it should be clear that ultrasound finding of PCOS are not mandatory for diagnosis, making diagnosis of PCOS. In adolescent girls, the ovaries may look polycystic in the absence of the PCOS. The diagnosis of PCOS can also be made from other criteria like menstrual dysfunctions, hyperandrogenism in the absence of PCOS, morphology in ultrasound. Then another biochemical, you can go for clinical examination. First things you do a history taking, clinical examination, in clinical general physical examination, then investigations, all investigation like ultrasound. Well, and first investigation is ultrasound examination. Second is biochemical and endocrinological test. You should go for a day to serum FSH level. Often rise LH level often rise more than 10 international unit per ml, and increase LH FSH ratio found to be 60 to 70% women, especially in non-obese women. But however, it is not necessary to diagnosis for PCOS, in not including the diagnostic criteria for PCOS. Test for biochemical hyperandrogenemia, total serum testosterone level may be normal, but there is elevated free testosterone level. PCOS due to decreased sex hormone binding globulin, serum testosterone level is more than 150. Dihydroepiandrosterone sulfate also marginally raised, epiandrosterone also raised. The other hormonal states like you go for a raised level of estrone markedly elevated, estradiol usually normal, serum sex hormone binding level reduced, serum prolactin level may raise, thyroid function test TSS may raise, 17 alpha hydroxyprogesterone level may be elevated like more than 1800 nanogram per dls. In late onset congenital adrenal hyperplasia, serum urinary cortisol level to rule out other causes of hyperandrogenism. The test for insulin resistance, you go for a baseline test on 2 hour 75 gram oral glucose tolerance is recommended for all patients with PCOS. Normal 2 hour blood glucose level is less than 140 mg. If you go for 140 to 199, the report is impaired glucose tolerance, while in diabetes it will go more than 200 mg per deciliter. Normal 2 hour serum insulin, that is less than 80 micro international unit per ml. If level is 80 to 100, this show insulin resistance, while the level is more than 300 to over in serum insulin level. that shows severe insulin resistance. 80 to 100 is shows insulin resistant. More than 300 micro international unit per ml is severe insulin resistance. The fasting glucose by insulin ratio is less than 4.5, so insulin resistant. The newest serum MH level has been observed to elevated in PCOS. The more than 20 picomole per liter associated with the high sensitivity and specificity to diagnosis PCOS. The test for metabolic syndrome, you can also go for serum triglyceride level, SDL, LDL, blood sugar, fasting, blood pressure 130 by more than 130 equal to 130 by 80. Triglyceride level more than 150 mg per deciliter, SDL level less than 50 mg per deciliter, blood fasting is more than 100, more than 100, more than equal to 100 mg deciliter. Obesity to circumference is more than 88 centimeter. The laparoscopy is not needed for diagnosis but for the therapeutic purpose. If performed, the bilateral polycystic ovary show multiple small peripheral cysts characteristic of PCOS. What are the consequences for the infertility, ovarian hyperstimulation syndrome, complication during pregnancy like recurrent miscarriage, gestational hypertension, gestational dilatation, preeclampsia, metabolic syndrome, long-term sequelae like hypertension, type 2 diabetes mellitus, atherosclerosis, coronary disease, hyperlipidemia, hepatitis, cholelithiasis, peripheral vascular disease, obesity, the endometrial hyperplasia and cancer, obstructive sleep apnea. Aim of management to treat symptoms of the disease to prevent the long-term effect of PCOS in later life. Hence, the treatment depends on the individual patients. Various treatment modality as follows. One is lifestyle modification. This needed in all patients but are more important in obese women. Weight loss is the crucial in obese women. If you go for a weight loss of 5%, that helps to treat mild hirsutism, helps to restore normal levels, hormone levels. Exercise, yoga advised to the patient in the form of regular moderate intensity aerobic exercise. At least you go for 30 minutes per day, at least 5 times a week. A diet plan has to be given to be patient. Avoid fatty foods, excess refined carbohydrate like junk food like pizza, burger, noodles. The apple is particularly suitable for adolescent species. It is often restore menstruation, ovulation as weight loss, reduce the insulin level, increase sex hormone binding globulin level, thus decreasing free testosterone level. If exercise and diet plan to provide that reduce weight, then drug like early start can be tried. If they are morbid obesity like BMI more than 40 kg per meter square or BMI is more than 35 meter square with high risk of obesity related condition with PCOS, bariatric surgery can be tried in selected case with significant improvement in the hormonal milieu and menstruation and infertility. The cessation of smoking and abstinence of alcohol or use of anti-moderate amount of alcohols and decreasing caffeine intake also helps. The treatment of menstrual, this is the lifestyle medication. Then treatment of menstrual disorder, the cyclical progesterone, the medroxyprogesterone acetate dose is 10 mg twice a day for 5 days or 10 mg once a day for 5 days in a month can regularize the periods in women who don't have hirsutism and who don't want to take post pills. It also prevents the development of endometrial carcinoma. PCOS patients subsequent years, it is used once every 3 to 4 months to induce withdrawal bleedings in an amenorrheic women. The combined oral contraceptive pills, low dose OC pills, mainstay in the treatment of PCOS patients not seeking pregnancy. They contain combination of estrogen, ethylene, estradiol with third or fourth generation non-androgen progesterone like desogestrel, gestrodin, drospirenol, and estrogen. What happens? Estrogen suppresses the androgen adrenal hormone, raises sex hormone binding level, thus reducing free testosterone level. The estrogen suppress the androgen and adrenal hormone and raise the sex hormone binding globulin level, thus reducing the pre-testosterone level. It also suppresses the LH level. Progesterone help to induce menstruation. The OC pill, what are the mechanism of OC pill that to prevent OC pill? What happens? Estrogen suppress the androgen production and decrease the sex, raises the sex hormone binding globulin level, so that the decrease the pre-testosterone level. What happens? The LH and the estrogen suppress the LH level. One progesterone part will help in the menstruation. Induced OC pill containing drospirenol, aspirin is preferred. It better than skin. There is no weight gain. There may be some weight loss. There is ameliorate the hyperandrogenic skin manifestation. Hirsutism and acne regulate the menstrual cycle. Lower the risk of endometrial hyperplasia and carcinoma. Apart from providing safe, effective contraception, the oral contraceptive pill. The oral contraceptive pill, the combined oral contraceptive pill containing 35 microgram estrogen, ethylene estradiol, 2 mg anti-androgen cyproterone acetate. The 35 is the drug of choice for adolescent with the PCOS with hirsutism. Treatment of hirsutism, oral pills with cyproterone acetate. Other drugs like spironolactone, protamide, finasteride, ketoconazole can also be used. Treatment of acne, oral antibiotic like tetracycline, minocycline, doxycycline, erythromycin can be used for along with anti-androgen therapy. Antibiotics can also be given locally as 1% clindamycin lotions or 2% erythromycin gel for severe intractable acne with scarring. So, isoretinoin or retinoic acid can be used. In highly teratogenic, should be avoided pregnancy while on it. Cosmetic therapy performed dermatologist, electrolysis or laser treatment can be done. Hirsutism with good center along with anti-androgen therapy. The management of infertility, management of menstrual disorder, management of hirsutism, management of treatment of hirsutism, management of menstrual disorder, treatment of acne, cosmetic therapy. These are the management of infertility. The weight loss and lifestyle modification are above to be continued. The cyclical progesterone combined pills or pill containing cyproterone can and be avoided if patient wants to conceive. Cyproterone acetate to be avoided if they want to conceive, but may used for vital bleedings human prior to the treatment of conception. Complement set is the drug. It can be used patient 50 single dose 50 mg daily for menstrual day 2 to day 6 followed by follicular monitoring. By transvaginous cone dose increase to 100 mg to 150 mg daily per 5 days. If no ovulation occur with lower dose, you can go for a 50 to 100 150. It induces ovulation. It induces ovulation. It induces ovulation 80% of women, but pregnancy rates is 40%. There is increased miscarriage rates 25 to 40%. The PCOS patient possibly due to corpus luteal defect. The insulin sensitizer metformin can be given concurrently and continue in pregnancy, maybe lower the miscarriage rate. Hyperstimulation, ovarian hyperstimulation may occur up to 10% of cases of the patient who are inducing with clomiphene citrate. In clomiphene citrate cases, resistance cases, dexamethasone 0.5 mg at bedtime can be combined with clomiphene citrate. For better results, it reduces androgen production. Dexamethasone reduce decrease androgen. Then for clomiphene citrate resistance case, failure to achieve population induction with 150 mg daily for clomiphene. You can add tamoxifen. The first thing, you can add dexamethasone 0.5 mg daily bedtimes. Then you can also add tamoxifen 20 to 40 mg daily for 5 days. That is day 3 to day 7. Menstrual can be tried. For clomiphene resistant, another point you can use letrozole 2.5 mg daily for 5 days, day 3 to day 7. Given in fact, it is very useful drug. Many use the drug of first choice. If above therapy fails to induce ovulation induction with PCOS patients, then you can go for gonadotropin, FSS, LH, and JNS analogs are used to induce ovulation. However, there is a risk of ovarian hyperstimulation syndrome, multiple pregnancy, and they should be used with great cautions. The infertile women, you can go for PCOS having hyperhomocystinemia can be given clomiphene citrate with 1.2 gram N-acetylcysteine daily, which is mucolytic drugs, which is insulin sensitizer. So they lower the homocysteine level also. Then women with insulin resistance, increase BMI, need metformin therapy with clomiphene. In vitro fertilization in PCOS, it is tried whether the method fails to achieve pregnancy. FSS use for ovulation inductions. The risk of OHS in PCOS of undergoing IVF vary from 3 to 33%. Pregnancy rate is 35% can be achieved with IVF. Then what are the insulin sensitizer that is available in market? These drugs are given as insulin resistance case. They can increase target tissue responsiveness and insulin, also helping the body to utilize the insulin more efficiently. These are the metformin. This is the most commonly prescribed insulin sensitizer used in PCS. It is second generation bioguanide. It facilitates the passage of glucose into hepatic and muscle cells. It reduces the insulin level, decrease the glucose absorption, decrease the hepatic production of glucose, and thus lower the blood glucose levels. It also reduces the total and free testosterone levels, by increasing the sex hormone binding globulin. It is given in a dose of 500 mg thrice a day or 850 mg twice a daily with the meals. It can also give in 1000 mg sustained release tablet at bedtimes. You can go over 500 TDS or you can go for 850 mg BD, or you can give a sustained release tablet 1000 mg at bedtime. It induces ovulations in 70 to 80% of women, pregnancy rate 30 to 40% cases, and it restore normal menses 62% cases. Does not cause hypoglycemia, does not reduce weight. Some studies they have been but less contraindicated in liver kidney measure cardiovascular disease. Side effect like gastrointestinal nausea, vomiting, dyspepsia, malabsorption of vitamin B12, lactic acidosis rare. It can be given with clomiphene. It's in routine use, not recommended in PCOS. However, it should be restricted to the patient with clinically evidence of insulin resistance, obesity, glucose intolerance. You can give acanthasis nigricans. Then another insulin sensitive, that is pioglitazone. The pioglitazone is the thiazolidine. It is another insulin sensor used only when metformin is not tolerated. Metformin resistant, it enhances the transcription of the insulin responsive gene, improve actions of the insulin, reduce the resistance, reduce hepatic production of glucose, dose is 30 mg per day. Roxicglitazone can also be used to pioglitazone, the same indication. The D-chiroinositol or myoinositol, D-chiroinositol is a vitamin B8. Is a post receptor of insulin sensitizer and intracellular mediator of insulin actions, enhances insulin sensitivity, improve insulin resistance. In a dose of 2 gram twice daily, total 4 gram per day, it has been used found to improve infrequent menstrual bleeding, ovulation induction, ovulation in Pcos patient, also help in weight reductions, improvement of dyslipidemia. It can be given for 3 to 6 months. Clomipins can combine with it, however, it is still a new treatment, is not well established. The surgical treatment is available, it is done less frequently for resistance cases, for failure of medical treatment. The laparoscopy ovarian drilling, it modification ovarian wedge resections is most less invasive, performed by unipolar or bipolar cautery or laser or harmonic scalpel. The ovarian cortex is punctured by foresight to depth of 4 mm for 4 seconds. Rule of 4, you should remember rule of 4 for both ovary. 4 sides, 4 puncture, 4 side punctures, 4 mm depth for 4 seconds. It destroyed ovarian androgen producing tissue, reduced peripheral conversion of androgen to estrogen. This reduction of androgen level, the LH level, and increase FSL ovarian link. The advantages of ovulation occur in 80 to 90% cases. 67% pregnancy rate. No one-time procedure is cost effective. And as compared to in vitro fertilization or gonadal cupping treatment, tubal patencies can be tested in the same sitting. The other causes infertility like endometriosis, tuberculosis can be treated. What are the advantages of you're doing in the ovarian drilling in the same sitting? You can go for other, you're going for a laparoscopy, you can go for, you can see other things also. You can see the tubal patency can in the same sitting, other causes like infertility, like endometriosis, tuberculosis. It reduces androgen level, LH level, less need for monitoring. Ovarian hyperstimulation syndrome or multiple pregnancy rate can be avoided by single ovulation occur with it. Disadvantages involve anesthesia, surgery. The post-operative adhesion may be from up to 20% cases can be reduced by hydroflotation, leaving some fluid inside. Premature ovarian failure can occur due to destruction of ovarian tissue by cautery can be avoided simple puncture cyst without cautery. The wedge resection of the ovary performed by past laparotomy but is major operation associated with increased adhesions, now replaced by laparoscopic drilling mentioned above. The prevention of issues and complication considering the long-term adverse complications. The metabolic syndrome, diabetes, hypertension, cardiovascular disease, dyslipidemia, and double cancer. The Pcos should be treated in all women. Adolescent girls should avoid obesity. They should change their lifestyle to lose weight. The patient's Pcos should alert by development of any of the above complication by regular monitoring. In case of abnormal uterine bleeding, endometrial hyperplasia, and ultrasound, endometrial biopsy should be performed to rule out atypical hyperplasia and endometrial cancer in the males necessitate complete surgery.